So this was a case of right isomerism or part of the heterotaxia spectrum, where both sides of the body are behaving as if both are the right sides, with arterial bronchus, trilobed lungs, and the midline liver. So in right atrial isomerism, as I said, both sides of the heart are as if it's a bilateral right atria with prominent triangular atrial appendages with prominent pectinate muscles on both sides, absence of the left-sided structures, and usually with pulmonary venous anomalies such as extracardiac TAPVC, which was present in our case, unbalanced right dominant AVSD, and pulmonary obstruction. So when to do the surgery, we went into a meeting with the surgeon, and he said that it was decided that since it was a case of balanced hemodynamics, we will wait. And there was, interestingly, no pulmonary venous hypertension, not much of it, because the child was having infracardiac TAPVC, but probably the channel was directly opening into the hepatic veins, and hence it was not much obstructed, at least not symptomatic. So we will follow it up and ultimately lead to a BD Glenn operation with or without a PA band, depending on the degree of pulmonary stenosis. So our second case was a 2.5-month-old baby, 4.5 kilos, had developed cough and cold with feeding difficulties for last 1 month and having deep cyanosis, which was improving somewhat with moist oxygen, bilateral creps, and in drawing, prominent precordium, hyperdynamic precordium, and a very prominent P2. So there was again a little bit of cardiomegaly, patches in the heart, but the ECG showed right axis deviation and prominent RV forces. And this is the echo showing a chamber formed just behind the left atrium, and we can see that the right-sided pulmonary veins in the lower right side is opening into the coronary sinus, whereas on the lower left side, if you see, the left-sided pulmonary veins are opening into the vertical vein and then to the innominate and then to the SVC. So this was a case of mixed type of unobstructed TAPVC, coronary sinus, as well as supracardiac. On the lower right side, you can see there is a small OS-ASD which is shunting totally right to left. So TAPVC, though, is a surgical disease, the non-obstructed variant behaves like an ASD, though with cyanosis, like a cyanotic heart disease with a increased pulmonary blood flow. These are the differentials, and they may be associated with heterotaxia syndromes, as was present in our case. And in the last year, this was our experience with TAPVCs in the newborn units. We had 6 infracardiac varieties, and out of the total, we had 3 as a part of complex diseases. 3 were obstructed, and they didn't have a good prognosis post-operatively. They didn't do well at all. So just to ponder over these points, when we have a TAPVC, then the obstruction is not only determined by the channel that is formed by the confluence of the pulmonary veins, but also in the interatrial septum, that is the size of the ASD, if restrictive, will lead to symptoms much earlier. They may not have any murmur, there may be borderline saturations and feed intolerance in the newborns, and sutureless surgical techniques has decreased the number of side effects of the pulmonary venous stenosis. And of course, in our cases, sildenafil was initially helpful in stabilizing the patients. But when we have heterotaxias, we should look beyond the heart as well, because the other systems may also have major anomalies. So thank you for your patient hearing.